Hello, this is Tom Davis. I'm Partnership Leader for Health and Nutrition for World Vision International, and this is a presentation on using barrier analysis to increase COVID-19 vaccine acceptance. While supply of vaccines and vaccine equity are definitely problematic, we also have the problem of vaccine hesitancy in many of the countries where we work. The gap between the green dots and the reference line on these graphs shows that we are still far away from having high acceptance of COVID-19 vaccines in many countries, especially in the African and Americas regions. And in some countries, vaccine acceptance is actually falling. So what is needed to increase vaccine acceptance? Well, first off, we need to have formative research to understand the varied reasons why people refuse COVID-19 vaccines. This includes use of tools like surveys and interview guides that are included in the WHO's behavioral and social drivers tools, but also barrier analysis to know which beliefs people have that are associated with vaccine acceptance and hesitancy. Second, we need to develop and use both activities and messages to change those behavioral and social drivers of hesitancy. And third, we need coverage and outreach mechanisms to engage with those who are vaccine hesitant through people that they trust. I'll mainly be talking about the first two things, but we'll touch on the third as well. A multidisciplinary group of global experts and partners, led by Lisa Menning at WHO, has developed a guidebook of COVID-19 formative research tools. This guidebook includes guidance on how to conduct that research and includes in the annex survey and interview guides, guidance for adapting the BESD survey and qualitative interview guide, and indicators. The most important thing that you can get from these survey tools is the percentage of respondents who report willingness to accept a COVID-19 vaccine, the most commonly reported facilitators and barriers to vaccination, and the guide mentions doing univariate analysis on things like gender, age, and employment status to look for correlations with vaccine acceptance. While that information is useful, I would argue that it's not sufficient since some of the most commonly reported barriers and facilitators of vaccination are in no way associated with whether or not someone plans to get a vaccine or not. I'll return to that in a few minutes. So here are the types of things explored in the BESD survey in addition to overall vaccine acceptance. Note that they include questions on 6 of the 12 determinants that we normally explore in barrier analysis, but there are also some notable omissions such as perceived severity of COVID-19, perceived divine will, and perceived positive consequences of vaccination. So I recommend you add questions on these determinants in your own surveys. Note it has some useful information in there about knowledge of vaccine providers and the preferred vaccination site, on vaccine stigma, and also on decision autonomy. The studies that World Vision and some other agencies are conducting are based on barrier analysis, which I hope most of you are familiar with by now. Barrier analysis is a rapid assessment, formative research tool to identify the behavioral determinants associated with a particular behavior, such as regular mask use or vaccine acceptance. And we do these studies in order to develop more effective behavior change activities and messages. Barrier analysis is based on the health belief model and the theory of reasoned action model. And a key feature is that you interview those doing a behavior, the doers, or intending to do a behavior, the acceptors, and compare their responses to those who are not, the non-doers, or those who do not plan to do the behavior, the non-acceptors. We obviously would rather study people who have actually gotten a vaccine as doers, but given the slow rollout in most countries due to a lack of vaccines, we have tweaked BA to look at acceptors and non-acceptors of vaccines. This comparison allows you to look for correlations between responses and the behavior, and in this case, vaccine acceptance, so you can better identify what is driving behavioral adoption. BA has now been used in more than 40% in lower and middle income countries, and analysis is done with a simple spreadsheet. Barrier analysis was used extensively during the Ebola outbreak, and organizations are now using it to study acceptance of COVID-19 vaccines, comparing responses from people that plan to get a COVID-19 vaccine with those who do not. These are the main determinants that are explored in these studies, things like perceived social norms, whether you think that people important to you approve of the behavior, but also perceived severity, whether you think that COVID-19 is a dangerous disease or not. Note that the determinants in blue are the ones that we added to our questionnaire for this particular behavior: trust in vaccines, trust in vaccine info from different sources, perceived safety of the vaccines, and also a few other correlates like educational level. A standard BA questionnaire, including both open-ended and closed-ended questions, is used. This is already developed and available to you, but you can modify it, add questions that might be useful in a particular country or context. You generally interview 45 vaccine acceptors and 45 or more vaccine non-acceptors over the phone, in person, or using an online survey. And with BA studies of staff and others with higher literacy and good internet access, respondents can receive a link to fill out an online survey, and this really makes it quite a bit easier. The results are tabulated by enumerators or program staff, and we have a new tabulation sheet that does that automatically that we're sharing, that we plan to be sharing with you at some point. The tabulated results, that is the number of acceptors and non-acceptors giving each response, are entered into an easy-to-use MS Excel barrier analysis table, which generates findings, p-values, and associations with vaccine acceptance. This is done automatically by that new BA table that I mentioned. Staff and stakeholders then use those findings on significant differences between acceptors and non-acceptors to create useful activities and messages that leverage enablers and reduce barriers to COVID-19 vaccination, and also to create monitoring indicators to track changes in those key determinants. So here's a brief excerpt of the BA questionnaire. You'll note it doesn't look all that different from other BA questionnaires we do. Some of the questions are open-ended, some are closed-ended. And if you would like to see the sample NGO staff BA survey on vaccines, you can do so by clicking on that link at the bottom. Note that one innovation we introduced recently with this was to provide some brief counseling points at the end of the BA survey that are based on the person's respondents. This is simple to do when you're using Kobo Toolbox. So for example, if the respondent says earlier he or she feels that few people will get the vaccine when it's available to them, a social norms issue, it explains that the majority of people in most countries plan to get a vaccine when one is available. This is one thing I really like about being able to do the questionnaire online. And here's what the BA tabulation table looks like, not different from other BA tabulation tables we've used for other behaviors. The sheet automatically identifies those responses that are associated with COVID-19 vaccine acceptance and the degree of association based on the estimated relative risk. Note that you can now adjust the p-value if you want to, so that you only capture those elements that might have a p-value of much lower, like 0.01. So at this point, we've conducted BA studies looking at COVID-19 vaccine acceptance in 22 countries and with 6 different groups: adults, adolescents, community health workers, health facility workers, staff, and faith leaders. Note that with faith leaders, rather than looking at vaccine acceptance, we looked at whether or not they were promoting vaccines in their faith community. We've published the results on some of these studies, for example, the one in Dhaka, and we have a preprint of studies in 6 countries. When you have the slides, you can click on these images to get to those studies. We have also presented these results to folks at COVAX, Gavi, WHO, UNICEF, Christian Connections for International Health, and now with the core group, and other agencies. We would love to hear from any of you who have used barrier analysis or other formative research tools for COVID-19 vaccinations. We feel that using barrier analysis gives practitioners a much better idea of what they need to be focusing on in terms of messaging and activities to promote a behavior, especially when compared to just CAP studies or focus groups. For example, here's an example of some beliefs on acceptance of COVID-19 vaccines in Bangladesh, which we completed in December of 2020. This is not barrier analysis data, it's cross-sectional data. Looking at this, what would you focus on? If you only had this data on prevalence of beliefs, or if you heard these responses in a focus group? Well, maybe you would want to work on those perceptions about negative side effects. After all, a lot of people brought those up when we asked what would be a disadvantage to getting the vaccine. Or maybe you could promote more advantages of getting the vaccine other than that it protects people from COVID-19. For example, talking about how children will be able to return to school once enough people are vaccinated, and that people will be able to return to a normal life. Those seem to be on some people's minds, and they sound like they could be powerful motivators. And maybe you would not want to work as much on talking about not getting the COVID-19 vaccine as an advantage, not getting COVID-19 as an advantage of the vaccine, since more than 3/4 of people already believe that. Or focusing on social norms, since more than 2/3 of people already believe that most of their family and friends will get the vaccine. Or maybe you have another favorite determinant to focus on. However, of those checked in green, none were found to be associated with accepting the vaccine in Bangladesh. They are most likely not driving acceptance. And of those rejected ones with a red X, not getting COVID-19 was an important driver, and believing that most of my close family and friends will get the vaccine was also highly associated with being an acceptor, that is, an intended doer. When we compare acceptors and non-acceptors in a BA study in a rural area of Bangladesh, in the Thakurgaon district in the Rangpur division, we found that of those 3 checked elements I just mentioned, none were found to be associated with accepting the vaccine. For example, negative side effects, when we compared acceptors and non-acceptors, responses were very similar. So these things are most likely not driving COVID-19 vaccine acceptance. Instead, here are the things that were most highly associated with intending to get a COVID-19 vaccine in Bangladesh. All of these are statistically significant associations. Social norms, for example, were very powerful in Bangladesh and in most all of the other countries where we've studied it. Respondents who believe that most close family and friends will get the vaccine were much more likely to say that they would get a vaccine. Respondents who said that most of the community and religious leaders wanted them to get a vaccine were also much more likely to seek the vaccine, as well as those who believe that most people in general will get it. So believing that not getting COVID-19 is an advantage of the vaccine was a very important driver. Perceived risk was also very important. Non-acceptors were 6.8 times more likely to say that they were not concerned at all about getting COVID-19. Perceived access was also very important, as one would expect. Acceptors were 4.8 times more likely to say that they expected the vaccine to be offered within 30 minutes of their home. This is why we want to use BA for other COVID-19 behaviors, and we believe other agencies should be using this tool in addition to other tools like focus group discussions, key informant interviews, and CAP surveys to make decisions around social and behavioral change. Many INGOs are already using barrier analysis, and the tabulation analysis can be done using a simple spreadsheet, which we've already developed and shared. So it's an easy tool to use. Given that we already have data on about 20 countries, why do we need to do more of these BA studies? Well, the main reason is that these determinants vary by country and geographical area and context. You can't assume that you'll find the same determinants where you work, so I believe we need to still be collecting data on this. For example, these 2 lists show the top determinants in 2 different countries in Asia. Note that there are 2 that are common in both, perceived social norms and access, but the others really depend on the country where they did the study. And I would expect we could very well find very different results by region of a country as well. This table shows which determinants of COVID-19 vaccine acceptance were found to be important in 9 BAs that were done in 4 countries in Africa, and which were more strongly correlated with vaccine acceptance. An X means that they were not found to be associated with COVID-19 vaccine acceptance. And green checks mean that they were. The more checks means the higher the level of association. So even if you do not expect to do any formative research on COVID-19 vaccines, I suggest you use very broad messaging. Unlike many behaviors, all the determinants seem to be in play with vaccination somewhere, and it's common to have 8 or more needing attention in a single country. This is probably one of the reasons that vaccine hesitancy has been so intractable. There's not one thing driving it, like trust in vaccines, despite the reductionist messages that you might hear in the media. We also did one study on regular mask use in Kenya, and we found a whole host of determinants that appear to be driving that behavior. The ones that were most highly associated with mask wearing were perceived severity of COVID-19, perceived self-efficacy, perceived social norms, and perceived divine will and personal agency. Once again, I think we need to do activities and use messages that addressed a lot of these determinants and use different channels, including faith leaders, if we expect to scale mask usage. We will be getting your ideas on how to address some of these determinants of COVID-19 vaccinations in a few minutes, but here are a few suggestions on how to address these. I won't go through this now, but feel free to reach out to us if you want to discuss these further. I've included links to a few resources where you can learn more as well. So here are some of the questionnaires, tabulation tables, the barrier analysis guides, and other guidance that we have available. You'll have access to these slides afterwards, so you might want to explore some of these tools. And note that we also have 2 tools in process. The first, a community health worker and faith leader COVID-19 vaccines video messaging guide. That guide walks the user through how to use BA results to develop your own activities and messages to promote COVID-19 vaccines. We also have Daniel Checkaround on our team now working on an asynchronous online barrier analysis training, which should be available for testing in the new year. So I hope this was helpful to you, and your responses, if you're in the actual session that we taught on this, were definitely helpful to us. Thank you very much.